All right. Should we just start by going through the questions as a panel? Yes and no answers are not acceptable. You have to add at least 3 words after the yes or no.
Perhaps I can start.
Absolutely.
I think that there's a difference what the outcome are, because if the outcomes are data we can get from routine care, I would answer it differently as if we need the patient to get the data. So for example, if we need questionnaires or in my case fitness testing, and then I think we need to tell patients why we do the measures. But in case that we look at survival and we don't need to bother the patients, I can live with not telling him or her.
So if you're changing their care with special ascertainments of outcome, then you feel if the control group is undergoing additional rounds of ascertainment of outcomes, you
then
feel
I
compelled to
think you
give them
need
more
to
information.
explain why you do this.
What do you think?
Yeah, well, it's good grading in the questions, because I think at least in this room there seems to be good agreement on the first one, saying that the answer is no. That may be agreement here, and it may be more controversial elsewhere. And there's been perhaps most discussion and least convergence on the last one, and I think the issue feels bigger and more complex the more we discuss it. Like, if we tell how much, in what detail, how many stages, and what stuck with me is this observation. Well, the more complex it gets, the more people you lose, and that's what I keep thinking about, and I'm looking forward to what we'll get to about it tomorrow.
And I may have understood something. Anna, weren't you saying you thought the answer to question 1 was a yes, rather than a?
We are talking about special.
And I should read the questions out loud as a public service to the panelists. They're the only people in the room who can't see them.
On the screen.
Behind, you're good? Everyone's good?
It's
Okay.
up on the screen.
All right. I'm on the no side as well for question 1, only because I think of the way I'm parsing it. I think in a usual care group, particularly if people are undergoing special ascertainment of outcomes because they're in a TWIX, I think they need to know they're in a TWIX.
Yes,
But-
okay, but that is another thing. If they're in a TWIX and you can use data from the TWIX, then you are fine.
Absolutely.
But if it's more in general, I think if patients need to do something, we need to explain why we ask these measures.
I definitely agree with that. And I think I had a preconception, which I now think is incorrect, that the usual care group in a TWIX is invariably not undergoing anything that isn't undergone by everybody in the TWIX. And as long as that's the case, then I would agree they don't need to hear anything about specific trials of treatment. Scott, what do you think?
I feel like I've said too much about it already, so I think I'll.
It seems to me that if patients have given some consent to be in an institute, at the very least, to be receiving care from an institution which has warned them that there will be studies underway, then it is acceptable that they do not give consent, that they are not told again. They do not again have to give consent for the study, do not again have to be told that there's a trial going on. But of course as Anne says, it's impractical if they're then being asked for information that's specifically needed from them. If they have to do anything active of that form, you have to give them a true explanation for why they're giving that, why you've asked them that data. So I think that's, should patients be told about treatments that they will have no access to? No, they needn't be if A, they gave consent of some form to engage in the TWIX, and B, if nothing active is required of them that would result in a deception.
That seems like a pretty strong position. I think we have a lot of consensus around it. Being mindful that we only have 10 minutes, I will throw in one other thing, which is, do you think there's a particularly strong obligation that if a trial is finished and results out, do you think everybody in the usual care arm should hear about that publication or the results? I'm not sure.
And hear that they were part of the study.
Yeah.
It seems to me, no. I mean, why should the situation change ethically when simply because the study's closed and published? But when it's in the interest of any institution trying to get a better relationship with its patients, that it feeds back information on research underway and what's being found and how that's being incorporated into new care.
Also, don't forget that one of the major advantages of trial within cohort is that we can do very long-term follow-ups. And the moment you decide to disclose, you contaminate. So
it can only be done if your trial is closed. And perhaps someone from Utrecht can comment on that, because we have some arrangements with our ethical committee about this point. So.
Well, I think it's also part of the stage informed consent that we ask patients up front whether they want to receive the results of the trial on an aggregate level once the trial is closed. So all patients who have actually indicated that they would like to receive this information will get the information. And it depends a little bit on the trial. We have trials where we have endpoints like complete pathological response, so we have the outcome immediately after surgery. So there it's not really a problem, and long-term follow-up is not an issue. But I agree with you that if you have long-term follow-up, then
if our outcome is developing severe mental illness.
yeah.
So that's like telling others, kind of very sensitive facts about someone else who is in the same study.
But do they know each other?
Look, it's a medium-sized city. Some of them do.
But you would give feedback information on an aggregated level, right?
Yeah.
So you just going to tell them whether the intervention that you have been testing is effective or not. That's it.
Well, I think they will find that out anyway, but the question is whether they should find out that they have been part of the control group.
We never do that.
Yeah.
We never tell them after the trial that they were
So
controlling
we
the
give the
trial.
information to all patients in the
Yeah,
cohort,
that's
independent on whether they are.
yeah. So I think that's much more
There is-
acceptable.
That makes sense.
There is one obligation that I think you do have to members of the control group, which is it feels to me they should be first to receive an effective intervention.
Why?
I think it's a quid pro quo for the contribution they made by being in the trial, even if they didn't know it. I think it's part of a social contract we asked something of you, you may not have known it, but you did it. And at least if there's a waiting list for this treatment, those who've contributed to the knowledge should benefit from it first. They've contributed something to it.
It's a very patient.
I think it depends a little bit on the type of intervention that you're testing, because we're looking at, for example, radiotherapy interventions, types of surgery, so there it's not really...
If the answer is that because of the way the trial operated, they're not able to benefit from it, of course not. But if there is a residual benefit that they could obtain, in other words, if the trial has showed that the treatment they didn't get was beneficial, and they could still benefit from it, then...
And it's easily accessible. I think that's also a condition.
Accessible to some, and to them I would put them at the head of the queue.
Let's take one more question and then go to question 2. Yes?
It wasn't a question, it's just a kind of confirmation in that I sit on, I've left now, but I was the chair for a research ethics committee in the Neurology Institute of Neurology, just across the road. And one thing that we, as an ethics committee that's had lay members as well, tried to really insist was that if there was like a kind of a randomised controlled trial, and some were in the control condition and some were in the experimental condition, that there would be some possibility that after the end of the trial, those in the control condition actually were then offered the treatment. And so I think it's I can understand what you're saying, but I think it's unethical if people are going to give their time and investment and not know exactly, what arm they're going to be in. And some of them only enter it because they're so desperate and they think they're actually going to be in the arm of the treatment, not to offer it to them. And I think also that makes people lose trust in them taking part in our research to think that, you know, they may also always end up in the not so nice conditions. So I think we also have to think about the relationship between gender with participants and patients who freely invest their time and commitment to a particular regime, but it may not be the one they originally wanted.
Thank you. Yeah, I think that's useful, and maintaining trust in a system like this is critical, so I'm glad we're talking about this angle. Let's at least get a hot take from everybody on the panel on question 2, which is a good one. What should people in a trial be told if their care is not affected in any way by the trial? Which I would parse as, what does the usual care group really need to hear? Anna?
I think this question is quite comparable to 1 in terms of answers.
Or 3.
Yeah.
Well, I think I would. It seems to me as if it's moving towards questions about whether you need pre-consent or not, or pre-notification of randomization. I'm not sure if that's the right way to parse it.
Yeah, I found these questions are a little bit too ambiguous to have answers, unless we sort of specify what they mean first and then answer it. But yes/no answers to these questions will leave too much ambiguity. So I think that's sort of what you just said, because you have to parse it. And I would say that it goes back to the question of whether or not, for example, if you're setting up a disease-defined cohort and you've submitted an application in which you're setting up a cohort with certain trials within it in mind, and that's what you're doing, and then you get cohort consent from people, but then you make a point of not telling, you know, people about your other part of your overall plan. If people find out afterwards, I think they do have, in the current climate anyway, a certain legitimate expectation that you kind of, on purpose, didn't tell me something. Now, that could be changed, as I said, over time, but at least currently, that would be a tricky thing to advocate for me.
Does anybody have a counterpoint to that position? It's something we were having an energetic argument about earlier. I mean, overall, I'm inclined to agree with that position, honestly. I do think there's which I would rephrase as, I think, leaving out a major detail such as the presence of randomization and not disclosing it to a subset of the cohort seems risky to me. What I would say is that's good, because it was 1 minute like 2 minutes ago. Right. So that's very exciting. But
go ahead. Sorry.
There is also a tremendous tendency in research ethics for responsibilities and kind of mandates on investigators to proliferate, and to proliferate irrationally, which makes it, to me...
That's precisely why I'm advocating my position, because I believe that the bigger challenge is not... you gain something by not doing the pre-randomization consent. Okay, you do gain something, all right? But you're going to be looked upon as people who are going to have to really justify why you're doing that. And that's going to create a lot more expectations of more X's and I's that you have to, or the T's and I's you have to do. It seems to me the bigger obstacle that people will face is not this 2-stage versus not, but can you convince your RECs or IRBs to actually have brief 2-stage consent, right? I think that's the bigger issue. And my strategy would be to say, look, we're covering all these bases, but because it's so low risk, we've covered this other issues. And I think it's a strategic point, not a ethical point in some sense.
So one question, with brief 2-stage consent, you mean that stage 1 and 2 is very closely together in terms of time, or?
Yes, and
Well, no, by brief, don't you mean it's a short consent?
Short, or it could even be. I don't know. I would think that some trials. Okay, so I want to go on record as saying we've all agreed on a specific clinical trial and the details, and we think that this is okay to do. I think in some of those you should go for a two-stage in which the first stage is cohort consent with opting out of the Twix. So it could be very brief.
Yeah. Okay.
I'm shutting us down.
Okay.